liver cases this week. How's that? Is that okay?
Yes, that's good. Is it, can you?
So this was a patient with prior tips and, you know, presented, I don't remember what presented with, but this is the, you know, this is the finding, and there's corresponding finding in the diffusion. So she had cirrhosis, the patient has cirrhosis, and so there's abnormal signal intensity in the portal venous system. So any thoughts or any concerns with what I've so far shown? Or should I just show the cases?
Well, what I see is like high restricted diffusion in the hepatic vein that is joining up with that tips.
Okay.
Is that what you're showing?
Yeah. But like, are you worried about this restricted diffusion? What will you be thinking about it?
Yeah, I mean, I want to look at the post-contrast images to see if there is tumor thrombus.
Okay, and so just remember that this was the pre-contrast. So you can see that the same areas have very high signal intensity on pre-contrast. So when we look at post-contrast, oops, this is not post-contrast, I apologize. Yeah. So our PAC's got an upgrade and it's like much slower than usual. So I apologize. So here's the post-contrast.
So an acute thrombus?
Yeah, I'm thinking less of a tumor thrombus and more of a just a regular thrombus.
Right. So this is just an example that acute thrombus can restrict, right? So even though this patient has, you know, pretty significant restricted diffusion in the thrombus, we should not call this tumor in vein. And, you know, so, you know, because there was high signal intensity in T1, you can always confirm lack of enhancement on the subtraction images if they ever load up. Anyway, but the, so you can see that on subtraction images again, there's absolutely no signal in these branches. So even though there was restricted diffusion, this is not tumor in vein. This is just bland acute thrombus. So the teaching point is that presence of restricted diffusion in and of itself is not enough to call, you know, to call something tumor in vein. This is a very interesting case. The patient came to us with this mass, and the clinical, this was an outside study, and the clinical indication was patient with growing, what do you call it? Let me just do this. Hemangioma, and potentially, you know, potentially do a biopsy. So this was the T2 appearance of the mass. This was the arterial phase. Right, so we see like very ugly rim, arterial phase hyperenhancement, and then the mass, you can see, becomes, you know, more and more enhanced in the delayed images. Slight heterogeneity. Here's the 8-minute delay. So, okay, so this was the mass. So another interesting part of this story is that this is in 2019. In 2013, this patient had an MR, and in that MR, there was a lesion in the same exact spot, fairly uniformly enhancing and maintaining the enhancement all through the phases. So this was called hemangioma, and I think this is, you know, I think if I saw this case, I probably would also call hemangioma. It's just, you know, small 1.5 centimeter enhancing uniformly. It enhances similar to the blood pull on all sequences. The only thing that's not quite perfect for hemangioma on this scan is that the T2 signal is not terribly bright. But I personally have seen hemangiomas that don't have such a such a bright T2 signal. So I don't think that if I've seen this case, I would have raised any concern other than just would have called it hemangioma and be done with it. So I think this is what happened with this case. In 2013, she just they called it hemangioma, and the patient went on their merry way. In 2000,
Victoria, just to be, I don't know, other side of the story, I feel like that T2 is pretty abnormal for hemangioma. So like maybe we could say, I personally don't think I would have called it a hemangioma, but I haven't seen one that looks like that. And if it was that kind of not T2 bright, I don't know. To me, that looks a little concerning, but if I'm proposing atypical hemangioma, I usually recommend a follow-up.
Well, so this is not our case. So I don't know if they qualified it as a typical or just said hemangioma. To be honest, I have seen hemangiomas which were absolute, everything else is typical and the T2 signal is just not perfect. There's sometimes sclerosing components. I don't know. I may have just called it hemangioma because it enhances really perfectly, right? Nice enhancement, and really follows the signal intensity of blood pull on all sequences. Absolutely nothing here to suggest anything concerning, really. And it, right? Like
well, following blood, I don't know. Like for example, it doesn't have the interrupted reticular nodular enhancement, and it also doesn't have like the very rapid flash filling hemangioma. So to me, this is almost in a I don't know. Does this patient have liver disease? Like this, like a dysplastic nodule could look like this, no?
This was not a liver disease patient. I don't know. It's still small enough to be, and this is the earliest. I don't know. I think that I would have not. I'm gonna be honest. I would not. I'm trying to be very like objective, right? Without knowing what happened to it, would I have raised any concern about it? And I personally don't think so. I think I would have just shrugged the shoulders and say, small hemangioma that just doesn't perfectly fit. Sometimes lesions don't follow what they need to follow. But so this is, I actually don't know if they said atypical hemangioma or just hemangioma, but this is 2013. Patient came back in 2017. I don't know if they came back for follow-up of this lesion or if they came back for some other reason, but this is what they came back with. So now you can see the lesion really, so you went from 1.5 centimeter to 4 centimeter. Now the enhancement pattern is quite different. Now you do have kind of nodular peripheral enhancement, but as it's contiguous, right? So as Aarti used the word interrupted, and that's not happening here. There's no interruption. There's just peripheral nodular, but not discontinuous, just a ring of irregular enhancement on arterial phase. But as we go further forward, it begins to kind of sort of fill in more. But again, center is very, very heterogeneous. And at this point, I think that I think, and here it is, still heterogeneous, although it does enhance more and more in the delayed images. So at this point, I think that, it's not a hemangioma. I think we all can agree with this. This was interpreted as growing hemangioma by the outside study. So patient, again, went back to their merry life, and then that was another 2 years later that they're, again came back. I honestly I don't know if they came back for the follow-up of the mass or if they just came back for whatever reason, but now the mass is 8 centimeters, and now it's really has the features of, malignancy with our rim arterial phase hyperenhancement, and it's growing. So if I just showed you this, right, it's, it's fairly classic for intrahepatic cholangio. If I showed you 2017 study, it's fairly classic for intrahepatic cholangio. The interesting part here is that, and quite honestly, the fact that it started out this, having this nice uniform enhancement is not unusual because small cholangiomas will do that. What's unusual here is that it's so slowly growing. It started in 2013, and at 2019, so 6 years later, the mass obviously grew a lot, but the patient was still confined to the liver. So this was, this was resected, and this was just straightforward intrahepatic cholangio. So, so that part was very unusual because usually cholangios grow fairly quickly. So this was a somewhat unusual biological behavior over time of this mass. But I think the teaching point here is that, even if the initial study was read as typical hemangioma, and all those subtle kind of clues were not picked up on or just dismissed, once the patient comes back a few years later, and the mass grew and it really does not look like hemangioma anymore, you really need to rethink the diagnosis rather than try to figure out, try to explain how it fits into the original diagnosis. But the patient is okay, which is good for the patient, but very, very unusual. Comment?
Yeah, no, I feel like this hemangioma being mistaken for a malignancy and vice versa is a common conundrum. So the more we can familiarize ourselves with both hemangiomas, like all the typical and atypical is really helpful. Steve says, I put a lot of weight on the ultra fast T2 here, not typical early on. So I think the T2, yeah, usually is very helpful. And then actually that patient was just lucky also in the location because it was so peripheral, then they could resect it, because otherwise anywhere nearer to like the hepatic veins or the center of the liver, it would have probably by that point been unresectable. So they were very lucky.
On more than one reason.
Yes.
So this is a more of a interesting case of natural progression of HCC. So this was, patient had Hep B, chronic Hep B infection, came in with this, fairly classic HCC, arterial phase hyperenhancement, washout appearance, a little bit of a capsule. So for whatever reason, patient didn't feel like getting treated, and then they lost to follow-up and came back. Let me just figure out how many years later. They came back a year and a half later. So let me just get that. Yeah. So I'll show you what happened to the patient. So the patient did not get treatment in our institution and adamantly denied getting treatment elsewhere. May not be completely true. Just give it a second. I'll show you why. I'm sorry about the slowness. There you go. So this is what a year and a half later, even on pre-conscious, you can see the rest of the liver has very abnormal signal. This main tumor has bright signal on T1. When we give contrast, you can see that it does have an appearance of a treated cavity with recurrent or residual tumor at the edges. Again, patient denies getting treated, but even if they got treated, they basically did not follow up. So now you can see a year and a half later what happens to HCCs when they don't get treated, just multifocal disease, classic HCCs everywhere in the liver. So unfortunately, so that's just a natural kind of, thankfully we don't get to see this a lot because patients get treated.
So yeah, I've seen a couple of cases like that big one there where they can auto-infarct.
Yeah.
But rare.
Yeah, but this one is just so perfect. And we have had patients where they did not realize that they actually were treated. I mean, oddly enough, we have history, we have situations where patients just didn't realize what they're getting. Notice how now you have vascular invasion. You can see, here invasion into the portal vein, and then here's another tumor in vein. So that's what happens to these patients. Another quick liver case. this is just a quick point. Um, this patient had a personal history of HCC, had it resected. You can see the stuff here. And about a year later, comes back with just these innumerable masses, all all with arterial phase hyperenhancement, all with washout appearances. So these are fairly classic HCCs. But the AFP is 3, which is normal. So this is just a cautionary tale that sometimes, especially when HCCs get very, very aggressive, the AFP may not be and may not be rising. So should not use normal AFP to make a decision whether or not you're looking at HCC or not. So this is just an example of quite an extensive HCC with completely normal AFP. That was the only point in this case. And the last case is, this is an interesting case for transplant centers that use opt-in criteria rather than LIRADS. So this was a patient, it was a transplant candidate, and you can see that we see a multiple lesions in the liver. Patient had prior treatment, and these lesions, many of them have arterial phase hyperenhancement and washout appearance, as you can see here, this one. And none of them have capsule. Here's what do you call it? Portal venous phase. You can see none of them have capsule, and all of them are under 2 centimeters, right there. So according to the opt-in, these are not HCCs. So for opt-in HCCs, if you have a 10 to 19 millimeter lesion, they have to have enhanced, arterial phase hyperenhancement, washout, and a capsule. And so these, based on opt-in, do not meet criteria for HCC. So based on opt-in, this is stage T0. This was treated. So according to LIRADS, these are all HCC, and this is multifocal HCC stage 4, T4A. Anyway, so the patient had a transplant because, they met the criteria based on opt-in, and this was on X1, this was multifocal, poorly differentiated HCC. So it's just a cautionary tale to be careful with opt-in and small HCCs.
Victoria, do you know what percentage of people now are still using OPTN versus LIRADS?
I don't. I really wanted to have, I was trying to lobby ACR to do a survey. I'm like, to do not just find out who's using it, but maybe get a better understanding of barriers to utilization. But it just kind of got died down, and COVID didn't help. So I don't know, but I know many transplant centers do use LIRADS, and we use LIRADS. We do not even report opt-in, and here, they, be honest, they knew that this is multifocal HCC, but they felt like this was, getting a new liver was patient's best chance of survival. And since, we didn't lie based on opt-in criteria, these are not HCCs. So he got a liver, or she got a liver, I'm not sure.
Yeah, that's, and poorly differentiated probably has a high rate of recurrence in the transplant.
Yeah, I mean, the patient is okay. So a year and a half later, they're still okay.
Good.
So
cool. Thank you.
okay. Hold on, let me stop sharing.
Christine, do you want to go?
Sure. Give me 1 second here. This. All right. Oh gosh. Okay. So this patient has this submucosal mass here in the stomach. And so I wanted to show this because initially we were thinking that it could be, because it's so well circumscribed, that it could be a leiomyoma or even like a GIST tumor. So this patient ended up getting endoscopy, and this turned out to be ectopic pancreas. So I wanted to show this in a companion case here. So this is another patient. Fortunately, I just have like a, one slice, but it was a patient that had a multi-phase CT for renal cell carcinoma. And you can see that in the first portion of the duodenum here, there's a structure that enhances basically identically as like the pancreas. So just, a couple of cases of ectopic pancreas. I guess something to keep in mind is that the ectopic pancreas can have all the same complications as the normal pancreas. So you can have pancreatitis and, even like adenocarcinoma, very, very rarely, but I just wanted to show these two cases.
Nice. I feel like the second case looks nicely like the pancreas, like fluffy and enhancing, but that first case, it almost looked more like a mass, like it didn't have a lobulated border as much, but.
Yeah, I agree. I mean, we didn't even mention that really in our differential when we first read the CT. It was only after endoscopy that they, they got some tissue, and then I think it would be really hard to call this prospectively, I guess.
Yeah, definitely. Cool, thanks.
Patient with these chest CT findings right there. The patient, this turned out to be Cocci. And on CT, our astute thoracic radiologist found all these little low density lesions in the liver and right there, all over the place. And
that was the astute abdominal fellow that was reading chest on call.
Of course. Fantastic. Great. I didn't know that part. I only saw the reporting, the final attending person. Anywho, so then they got, we got an MR, and we see all these little lesions, right? Here's a T2. What do y'all think?
Classic Coxy. I'm just kidding.
Nice.
I guess with the lung findings, I don't know. Does it? I guess I would presume it can also go to the liver.
That's got to be in the differential.
Oh, Coxy, yeah, oh for sure, right? And then some of them are rim enhancing, like right there. So this came back as metastatic prostate cancer. This patient also has a history of prostate cancer and it's on androgen deprivation therapy. So differential diagnosis, I guess, is a key point. I feel like it would be very hard to clearly say it's Coxy over, Mets, for example.
Yeah. Coxy is more in the Southwest, right? Do you guys see a lot of it?
We have quite a bit.
Yeah, I think they throw it into every chest CT.
Yes.
Have you seen it in the liver?
That's it. When I saw this, I was like, well, maybe it's not Coxy. What if it's like squamous or something that's metastasized, even though that's weird, but I don't know.
Yeah, have you guys seen it in the liver or like in
No.
Okay.
Never seen in the liver.
Yeah, last week somebody showed a case of, what was it, blasto to the adrenal glands.
Oh yeah, that's right.
But I've never seen any of these.
What's that?
I don't have any cases of either blasto or histo or Coxy. Maybe I'm missing it.
Maybe you will get more cases soon as we continue these conferences. So this second case is a patient with a history of gastric cancer, remote history, like over 10 years ago or something like that, new to us, and had a non-con CT, just like for abdominal pain. And I'm showing this because it's, it's non-con, we don't have oral or anything like that. And so this is more of an eye test. So what do you guys think?
I thought I saw something mass-like up by the splenic flexure of the colon, but right there. Oh, that's
Yes. There's something posterior to the liver along the suture line. The patient had a partial gastrectomy for prior gastric cancer. And then patient had a subsequent contrast enhanced CT. So that was mentioned, this finding, the other, so and then this renal isodense lesion. And then, so the patient got a CT abdomen and pelvis to evaluate those findings. It was a multiphasic study, and the thing in the stomach, it wasn't enhancing. It almost, to me, looked like a marginal ulcer, or it looked very fluidy, and it doesn't enhance on it on multiphasic study. So I thought that was not malignant appearing. The renal lesion, it was not enhancing either on any of the phases. So I thought it was hyperdense on, so maybe a proteinaceous cyst or something Bosniak 2E. And then the other finding contrast was this. And so in retrospect, when you look at the other original non-con CT, it was there. It was just really hard to separate from the adjacent bowel. So the teaching point, what is the teaching point? It's really hard to see these things. And so it's really, I guess, I mean, I'm not sure what the secret sauce is to kind of like not miss these lesions in the small bowel mesentery. Any pointers from anybody?
some people have been politicking lately about returning to more positive contrast on CTs routinely in patients that have had cancer history, especially. I know Perry Pickard was on that soapbox at the last SAR, I think at least once, and there was a session, of course it was sponsored by a contrast agent company, where a bunch of speakers got up there and said, you know, we should be doing this. I haven't seen an evidence-based approach to, you know, figuring out what we miss when we don't have positive contrast. My practice has not returned to giving a lot of positive contrast in most settings. So, but this is one where, you know, you question. You're like, I wonder if I would have seen that better if all the bowel loops were white.
Yeah, I completely agree. And I mean, this patient, this patient is like, doesn't have a lot of fat either. So I know from like literature, if the BMI is greater than 24, apparently peritoneal findings are, you know, I mean, you don't need oral. I mean, in this, I don't know, this patient doesn't look like they have a BMI of 24. So in patients less than BMI of 24, I know we typically advocate for positive oral contrast, in addition to patients with a like malignant history. So
Nelly, another thing that I've done recently is just add a mesenteric sweep into my search pattern, because at RSNA I saw a presentation about how we miss a lot of mesenteric nodal mets from neuroendocrine tumors. And it's usually on multiple exams by the time we catch it.
Yeah.
But in retrospect, you can see it if you really look at the mesentery. So I've just kind of added that, like an additional sweep through the whole mesentery there. And I think on this non-con, I mean, it would be so hard, but on that post-contrast, I think it does pop out a little bit more.
Oh yeah, for sure. I mean, it's like, definitely agree. I mean, on a post, it's like hard to miss, but yeah. Okay, cool. Those were my cases.
Okay, anyone else? I have a few.
I can share one quick.
Okay, go.
An elderly patient that had intermittent symptoms of abdominal pain over like 10 or 15 years. And we were just looking at the exams trying to see if we could figure it out. This is the most recent, and this is the prior. The prior made mention of abnormal configuration of bowel loops. And so we looked at that, and if you follow the upper GI here, you can follow the duodenum to here, and then you can't really see a transverse duodenal segment. It's kind of like this is the mesenteric root, and you're looking for a bowel loop going across here, and instead they kind of cluster up here in the right upper quadrant and go down. And There's also a mesenteric vein that normally goes around the back towards the ligament of Treitz there, and that one is going down and away to the right. So this was, then it kind of does cross back over, but it's much lower here. So this was described as, malrotated bowel in an adult. I don't think they speculated at the time whether or not it was related to the patient's symptoms, but interestingly, the more recent one with no surgical intervention of any sort has a transverse duodenal segment here and a first jejunal branch that goes around the backside of the mesenteric root like it normally would. I mean, it kind of continues on there beyond that. So this is the first time I've ever seen it, and I have seen from time to time adults that are malrotated, and there's been some interesting cases over the year. I'd never seen one where it looked like it spontaneously went back to a normal anatomic position. And again, we sort of speculated as to whether or not this may or may not be related to the patient's long-standing symptoms. If it was felt warranted, I suppose a surgeon could go in there and try to correct the anatomy and tack things down. Obviously, in the peds population, they can present with obstructions at the lad bands and midgut volvulus and terrible things. But a lot of adults that get by from that period end up with malrotation that's just dealt with. But I'd never seen one that kind of went back to its normal anatomic position by itself. So that was new on me.
Steve, that's super weird. And the only thing I can think of is that it wasn't tacked. It's not tacked at the ligament of Treitz.
Yeah.
And therefore there was almost like an ability for the fourth portion of the duodenum and the jejunum to herniate back through to the right side.
That's exactly what I was thinking. It must somehow be mobile enough to get back to anatomic position and then out of position and flipped around the mesenteric root the wrong way every once in a while. Because there's another exam earlier that looks a lot like the malrotated one I showed, and that was these are separated by years. So there's 2015, 2016 exams, then 2020 exams where everything's malrotated, and then no surgical intervention, but late 2020, and things are more in their anatomic position again.
Wow, interesting. I have seen when I do see an incidental malrotation, I've kind of mentioned it, but if they're not obstructed, they usually don't do much about it.
Yeah, there's not generally an intervention if the patient's not obstructed or symptomatic in some way.
Cool. Okay, this is my first case, and I want you guys to speak up or put some answers in the chat. So these are testicles, and you can see that there is this hypoechoic lesion in the right testicle with some flow in it. Something outside of the testicle as well. And on the left side, there was a similar appearing hypoechoic lesion in the testicle. And so bilateral testicular masses with some flow. What do you guys think? Yes, Rupa got it. So these are adrenal rests or TART, and so testicular adrenal rest tumors. And in this case, this patient actually came with a history of congenital adrenal hyperplasia, and they were specifically asked us if there are TART tumors in the testicle. And so we didn't have to give a differential. I think if I had just seen this de novo and they did not have that history, I would give the differential of testicular malignancy versus, I don't even know if I would have thought about it, but this is actually kind of a classic appearance. They tend to be eccentric. They're most 90% of the time they are bilateral, and they are usually along the mediastinum testis, which I'm not sure I can really tell in this case, but They are kind of eccentrically medial like this. I have a companion case. So this patient, let's pull this down. So this is another patient who did not come with a history, and then this is what we saw, which was even larger, hypoechoic, very vascular lesions. And they were also bilateral. This one is like much more extensive. It has some areas of almost calcification in it with shadowing. And then to show you the left side also looked like the entire thing was kind of almost diffusely involved. And actually I had shown this case to Cookie and she immediately said, show me the patient's adrenal glands. You can see that they are thick and enlarged and hyperplastic. So this is kind of the classic series of things that you'll see in patients that have congenital adrenal hyperplasia and testicular adrenal tumors. So I have a couple of slides, or just, yeah, a couple of slides about it. So this is what we call TART, testicular adrenal rest tumor. They're usually less than 5 millimeters and asymptomatic. However, if they have congenital adrenal hyperplasia, then they can develop these masses. They're bilateral, eccentric. They can be typically hypoechoic, less likely hyperechoic, but they're kind of heterogeneous and variable. And they're usually along the mediastinum testis. They have no malignant potential, but they can cause damage to the surrounding testicular tissue and infertility. So sometimes they will either resect these or at least do sperm preservation in patients who have these so that they can use the sperm later if they want to use that for fertility. And the treatment is for the congenital adrenal hyperplasia is corticoid replacement therapy. And the reason this is because this is sort of the, try to get to my next slide. This is what's going on in congenital adrenal hyperplasia. Basically, they're missing this enzyme. This goes back to medical school. So they're missing this enzyme. So they're not making enough cortisol and aldosterone. This leads them to have salt wasting, and also they can go into Addison's disease and adrenal failure. But because of that, they also have increased androgens. So one of the signs in a baby would be like a female, if they have like virilization of their reproductive organs, this is a sign of increased androgen production. It could be CAH. There's a whole endocrine workup that they can do for this to see what your sodium, potassium levels are, to see if you may not have aldosterone. And then this is why we get these hypertrophied adrenal glands, because these adrenal glands are now pumping out these androgens. And then also there's just generally an elevation in ACTH levels, which is why, because you don't have enough cortisol. So these testicular rests, the adrenal rests in the testicle are activated, and then they become hypertrophic because they're trying to produce cortisol. So if you give the patient glucocorticoids, that can cause these adrenal rest tumors to regress. Any questions?
What's the key to the diagnosis is the bilaterality and the...
Yeah, so either it's nice if they already have like a clinical endocrinologic diagnosis of congenital adrenal hyperplasia, and then they look for these tumors. But otherwise, yeah, if you see bilaterality, you can raise the possibility. They can get an endocrine workup. And then if you have an abdominal CT and you can see a hyperplasia of the adrenal glands, that can help you kind of clinch it. Adrenals, and sorry, their testicular masses were so extensive. It was pretty scary to me. I was thinking maybe these were like non-germ cell tumors. But actually, yeah, Cookie immediately asked me for an abdominal CT, and that's what they were. So, okay.
Do you, I mean, sorry, I don't know if I missed this, but do you have to have those adrenal findings? Like what if the adrenals are normal? Like,
yeah, I don't know. I did read, like, there is a highly variable kind of penetrance of CAH. So some people like a lot of people will present as babies, right? So when the pediatricians are doing their exam on the external genitalia, then things are, and or they have like all sorts of health issues, they start doing this endocrine workup. So most people that have this like, more severe form will be diagnosed as a child. But some that have a milder form will present in adulthood. And one of the biggest things actually in males is infertility. Because like, for example, you could see here that this, this tumor, in this patient, they're taking up like most of the testicle. They actually did sperm extraction for him. And so that he could have that option before like it takes over the entire testicle, because it's not inconsequential to be on long-term steroids as well.
If you don't have endocrine abnormalities, what is percutaneous biopsy something that we do now? Or, I mean,
that was actually something I read in a paper. I've never really done it. I mean, I would say probably sometimes this is a retrospective diagnosis, like we presume that this is a tumor, but when it's bilateral in a young patient, it's a little weird. And also they want to preserve things. So we have occasionally, done biopsies, or they've done a unilateral orchiectomy. And then if they get the diagnosis, I presume sometimes they might get this diagnosis and be like, oh, okay, that's probably what's going on in the other testicle.
Cool.
But yeah, I mean, before I saw this case, and then the next one, my colleague Melina showed last week, and basically the indication came, as they look for TART tumors.
Yeah, because if I was just looking at this without, the like pretest, like a high pretest probability, I mean, it would only be a differential. Like there's no way I would be able to say it's not malignant.
Yeah.
In the absence of, endocrine abnormalities, concurrent CT, or in this case, high clinical suspicion.
Yep. Okay. This was an interesting case. So this is a patient 5 years ago, and you can see they've got renal cysts, but they also have renal masses. So here's one. So they have bilateral, fairly solid appearing renal masses, that some of which have kind of like central necrosis or central scar.
Was the patient of VHL?
They do not have VHL, and their pancreas is normal. And anyway, we were concerned that this was multifocal, some kind of, there's a lot of new genetic basis for RCC. So we thought they had multifocal RCC. So we biopsied these two left-sided lesions, and they both came back oncocytoma. Actually, they came back oncocytic neoplasm, but they did not have any more worrisome features for chromophobe, at least on the biopsies. So we basically decided, what'd you say?
No, I mean, it made me think of BHD.
Yeah. So
they have like lung findings or skin findings.
Exactly. So when you see multiple oncocytomas, you think about Burt-Hogg-Dubé. They did not have any lung findings. And then this is what they look like now 5 years later. So you can see that they've grown. And so we were debating about this in urology tumor board, like, should the urologist go and start plucking out some of these and all this kind of stuff? And so we basically were talking about, this patient has what they call oncocytosis. So I made a slide about that. Let's see. Okay. So renal oncocytosis can be sporadic, or it can be related to Burt-Hogg-Dubé. And the really important point here is that, so there is this entity called oncocytosis. I found a paper where they did a review of 3,000 renal specimens from Memorial Sloan Kettering, and about 20 of them had this entity called oncocytosis, where there were multiple oncocytomas in both kidneys. So it's a known thing, and some of them can progress towards chromophobe, because there's that spectrum of abnormality from oncocytoma to chromophobe. But none of those 20 patients at Memorial Sloan Kettering in a 20-year period developed metastatic disease. And the big thing for these patients is that they can get chronic kidney disease because their kidneys are being overtaken by these tumors. So, one of the things that my urologist said, and that they said in this paper, it was in the Journal of Urology from Memorial Sloan Kettering, is that you don't want to necessarily go plucking out all of these lesions, because you can decrease their renal function even further. So even though this can be a progressive disease, the lesions can get larger, there is still a low rate of developing metastatic disease. And, you can see here that the renal parenchyma is getting more and more taken over by these lesions. So the main risk here is chronic renal failure. So our patient, they're just watching them, hoping that this kidney hangs on long enough, all this parenchyma here, but they're not going to go out and take out some of these. It's different than like in VHL, where we talk about when they get larger than 3 centimeters, we start talking about doing surgery because of the higher risk of metastatic disease.
I don't know if anybody out there has experience with nuclear medicine sestamibi to try to suss out what's a oncocytoma versus an RCC, but there's some papers out there that, make some interesting evidence base to support that.
No, I feel like we always debate oncocytoma versus chromophobe, and ultimately even biopsy, it's not definitive. So, but yeah, it is. But both of them are increasingly known to be indolent. So I think that like when you're on that spectrum, if the patient's older, they have multiple, you want to be careful about doing surgery. Nelly, this one's for you. Are you still there?
Yeah, I'm here.
Oh, okay. Anyway, this is another oncocytoma, and it's just a cute one where it had segmental enhancement inversion, kind of. So anyway, basically this is the arterial phase, and this is the delayed. And you can see that there's avid enhancement along the
Oh, cute. Yeah.
back on the arterial phase that washes out later. And then the central hypoenhancing part gets more enhancing later. So that's the feature called segmental enhancement inversion. It was initially thought to be a promising sign for oncocytoma, but now we know we can see it in chromophobe. But either way, when I see that now, I bring up this oncocytic neoplasm entity. Okay. This is a case of a patient who had this mesenteric mass with these small little calcifications in it. So what do you guys think?
Carcinoid?
Carcinoid is the top.
Yeah, exactly. So it looks a little ill-defined. It's got some dystrophic calcifications. It doesn't look so extensive. When I see more extensive calcification, I think about sclerosing mesenteritis. There is a little bit of stranding and maybe a pseudocapsule here, but basically we said neuroendocrine lymph node met versus less likely sclerosing mesenteritis. This was biopsied. It came back all inflammatory and fibrosis. And so they said it could be sclerosing mesenteritis, but we cannot exclude fibrosis related to neuroendocrine tumor. A year went by and it had grown. So what do you guys think now?
I'm still suspicious for the neuroendocrine neoplasm.
Yeah, exactly. So we were still suspicious for it. So then we did, hold on one second. I'm going to try to.
What about a dotatate?
Yeah, exactly. So we did a dotatate.
Exactly.
And I'll show you the dotatate. You can see the liver and spleen lighting up. The unsynaptic process of the pancreas is a popular place to get a pseudo lesion because it has more somatostatin receptors. And then here is our lesion here.
Kind of warm, but not real hot.
Yeah, exactly. So this this was called hot, but not as hot as liver, which is a clue. So could be still a neuroendocrine tumor. And I would say that isn't exactly correct. So two things. One, if it's not very hot, then it could be a neuroendocrine tumor, but it would be more likely a more poorly differentiated neuroendocrine tumor, not a well-differentiated one that has like a lot of somatostatin receptors. And the other thing I learned is that sclerosing mesenteritis can be avid because it has macrophages, and also some lymphocytes can have somatostatin receptors. So they went in and did a surgical resection of this, and this came back sclerosing mesenteritis. So what'd you say?
That's very mass-like.
Yeah, and it progressed, like the size progressed, right?
Yeah.
And so take-home points here are that sclerosing mesenteritis can be avid even on dotatate, but it won't be as avid as a well-differentiated neuroendocrine tumor. And sclerosing mesenteritis can be progressive and can even grow in 6 months or to a year. So there's a big range. It can be either very indolent or it can be progressive. When it is progressive, they will be sometimes worried it's going to obstruct the bowel, so they can treat it with steroids and also tamoxifen and other kinds of like chemo and radiation for really, really progressive ones. But yeah, this was just kind of one that was growing. We got tricked by the dotatate, and luckily for the patient, it's just a sclerosing mesenteritis. Okay, and then I just have one more acute case. This is a patient that has a kind of extensive high rectosigmoid cancer here. That's not really the point of my case. You can see though that it's extending beyond the wall, so very aggressive, long rectal cancer. And the point of my case is that we were looking at, all these lymph nodes around it. And there's even a lymph node here. And there's a lymph node here. And so we said that this was called a para-aortic lymph node. And I guess the teaching point here is that you can see it's right next to the IMA. And so we should call this an IMA lymph node, because an IMA lymph node is still in the regional nodal distribution, whereas a para-aortic lymph node, truly like above the IMA level in a para-aortic location, would be a distant node. So just be careful if you see a high node, if it's next to the IMA, it's still called an IMA node. Okay, that's it for me. Anyone else have cases? Okay, well, stay warm and have a great day, everyone. See you later.
Thanks all.
Thank you. Bye.